With a glow of the screen and a heart full of pride, he's talking with experts from the world far and wide, broadcasting his voice through the good and the grand, on YouTube, Facebook, LinkedIn, and X across the land. Every Saturday morning, he's the urology man.
Hey, good morning, everyone, and welcome to the show. I am your host, Vic Senese. If you've been with us from the past, you might have noticed, hey, we got a theme song now, trying to do a little something different in the show. But anyway, we've got a great show for you today. We're going to be talking about Multiphze, the enclosed bladder irrigation system. We're joined by Dr. Albert Mikhail, a fellowship-trained expert in minimally invasive and robotic surgery. His career journey is unique. He first earned a degree in electrical engineering and worked for the California Department of Transportation before pursuing medicine. His medical training took him across the country, including 4 years in Philadelphia for medical school, 6 years in Los Angeles for urologic surgical residency, followed by 2 years at the University of Chicago for fellowship training in advanced robotic and minimally invasive surgery. Since completing his surgical training, he has gone on to complete over 3,000 minimally invasive and robotic surgeries. He has published more than 20 peer-reviewed articles in minimally invasive surgery and previously directed his hospital's robotic program and chaired his hospital's local product council, helping integrate innovative devices into daily patient care. In addition to his clinical work, Dr. Mikhail is involved in advancing safer, more efficient urologic procedures. He's also co-founded and developed Multiphze, which we'll be talking about today, which offers the first and only enclosed bladder irrigation system featuring a rotatable syringe and independent ports designed to improve safety, efficacy, and reduce costs in managing hematuria. Now, please help me welcome Dr. Albert Mikhail.
Hi, Vic. Thank you very much for having me. I appreciate this opportunity to be on your show, and great setup. I love your show.
Oh, great. Glad you like it. And Lori's joining us today. Lori, welcome to the show.
Good morning. Welcome, everyone.
So we got a bunch of urology practice. I'm sure Lori can attest, as I can say, that one of the hardest things to deal with is bladder irrigation. It's a tedious job and it's a messy job, and you're going to make our life a lot easier, right?
That's the plan. So yeah, we're here to revolutionize the way we see hematuria.
All right. Well, let's not keep the audience waiting. Let's go right to your show.
All righty. Well, thank you, Vic. So as Vic mentioned, I'm actually an engineer and I'm a practicing urologist at this stage in my career, but I've also mixed the two together and started Multiphze LLC, which basically is a medical device company focused on medical safety, workplace safety, and efficiency. And our first product is the Multiphze Enclosed Bladder Irrigation System. As Vic alluded to, it's basically a syringe, a double barrel syringe with its own integrated irrigation line and drainage bag all connected together. So it's basically rotating between the phases, thus multiphase. So just to go over hematuria, a lot of us have dealt with this, whether it's bleeding from the kidneys, from the bladder, due to anticoagulation therapy, recent surgery, or active cancer. Hematuria is one of actually the most common causes for urologic ER visits. In fact, in my medical center, that's the number one cause for urology, for ER visits, followed by kidney stones and difficult catheters, urinary retention. So when patients show up to the emergency room or in our clinics, or even during surgery or in the recovery or med surg, when they have hematuria, the first thing we need to do is what's called manual bladder irrigation. We need to get all the clots out. And then we can sort of convert to what's called continuous bladder irrigation. But when we do manual irrigation, we have to vigorously irrigate all the clots out. If we relied solely on continuous bladder irrigation, where it's just gravity fluid draining into the catheter and urine then draining out again by gravity flow, it could take forever for a big clot to dissolve out or erode out, I should say. But sometimes the catheter is going to get clogged. And again, you need to go back to manual irrigation. So manual irrigation is the first start. You need to get all the clots out, pushing fluid in, agitating the clot. And for a lot of us, this is what we've been using, the standard irrigation kit, for several years. And for a lot of us, it's PTSD, especially when you have to irrigate 2 to 4 liters. And in fact, the most I've had to irrigate once was 9 liters due to the patient being so anticoagulated. I couldn't take him to the operating room, and his bladder was so full of clot. I had to sit there and irrigate through 9 liters. And the whole time I had the nurse flanking me. And you can see from this video that I'm going to share with you right here that basically it's a very messy procedure. It takes 2 people to do the bladder irrigation. It's an open system. It's amazing how we become complacent to bladder irrigation. With other modalities, like when drawing blood and all these things, we develop needleless systems, all these different ways to mitigate blood-borne pathogen risk. But with bladder irrigation and hematuria, to date, we have not. So you can see here the user is basically filling the syringe, irrigating the bladder. They're going to be pulling out clots here. And you can see there's already some blood stains. So in this video, they've already started irrigating. But you're going to see here they're going to pull out a large amount of clots here in a second. And basically, they're going to dump it in this 1 liter reservoir, 1 liter waste bin. So they have a 500 cc sterile fluid collection and a 1 liter waste bin. And you can see the sterile fluid collection is already contaminated. It's already getting splashed. And it takes 2 people to do this, because you'll see here as this basin fills up with fluid and this fluid sort of runs down, you need someone constantly sort of filling and emptying this. And it's sort of a 2-person job. And you can see here this constant connection and disconnection of the syringe. You know, this is not sterile. I mean, the user's gloves are not sterile. The constant contamination of connecting the syringe to the patient's catheter, touching his gloves, putting it in his sterile meter. So it's just amazing how we become complacent to bladder irrigation. So let me go back to the PowerPoint. So with regards to this issue, the aha moment came, by the way, when I was irrigating during surgery. And just to show you here, here's some photos from bladder irrigation. And you can see it's just a bloody battlefield when you're done. There's bloody linens. And these bloody linens just can't be thrown in the wash. They have to go through biohazard decontamination. And you can see here when you're irrigating by yourself, sometimes you just fill these bottles up, and that's 3.5 liters of irrigation just for this. But if you can imagine, the gurney is soaked. The patient is somewhat traumatized by seeing all this bloody fluid sitting at their feet, the bloody linens as well. And you can see here, just by looking at this container, how much splash there is every time you empty that syringe. Even on these bottles, there's splash here, but it may be hard to see on this video, on this PowerPoint, but it's just a bloody battlefield. And then this is where we've come to revolutionize this. As I was mentioning earlier, the aha moment came when I was actually irrigating in the operating room. And the nurse kept putting her hands up to block the splash, even though we were all fully gowned. And so that's when I realized there's got to be a better way. And as I mentioned before, it's basically a double barrel syringe with its own irrigation line and drainage bag. And I'm going to sort of go to this video here where it shows how the kit comes. It comes wrapped basically in a backer card. It's sterilely with a sterile drape around it. And it's really going to be a spike. You spike it into a fluid source, connect it once to the patient's catheter, and you just hang your 4 liter drainage bag on the side. And it's going to, and basically we have a rotatable inner barrel, and you can hear every time you basically click, you can hear the click and feel the click every time you're between phases. And this is a 120 cc syringe versus a standard 60. And you can see it here. It's basically a fill, irrigate, and once you get all your clots out, you're going to rotate the syringe once more to the left, back to drain, and you're going to waste it in the bag, and you just go back, rotate a couple times to the right again, and you're back in the fill phase. So obviously it's a novel idea. Every time we've gone to conferences, people say, how come no one thought of this sooner? And it's the only enclosed system and OSHA compliant system for manual bladder irrigation. And think of it as extended PPE. And you can see here, not only is it used on the floor, med surg, or clinic, but it's also used in the OR. As you can see here, this is a first-time user using it in the operating room. They're using it connected to a resectoscope. So I actually use this for all my TURP cases, all my large bladder tumors. You can see it fits easily under a resectoscope using a resectoscope adapter or cystoscope adapter. And you can see here the surgeon's going through the fill, irrigate, drain phase, as you can see here. And it's really a matter of just putting your finger once and rotating through the different phases. You can see here going back to fill, irrigate, and then drain, if you will. So nurses love it when I use it for my TURPs. They hate using the E-Lick, and I personally don't like using the E-Lick evacuator myself. With this one, I just park it on the patient's abdomen, and when I need to irrigate, I just go through the fill, irrigate, drain phases. And what the nurses pointed out to me, how quick the irrigation went, but more importantly, they didn't have to open up 10 to 21 liter bottles on the back table trying to submerge the E-Lick. And here it is at the end of the case. You can also use the tip, take the cystoscope adapter off, and you can start irrigating through a 3-way catheter or a 2-way catheter. So you can just transfer it and start irrigating just as well. And what's nice about our system is once you're done irrigating, you can move our irrigation line to the inlet port of the 3-way and our 4-liter bag to the drainage line, and you can start immediate CBI with our device as well. In fact, the nurses love it when we use it on a robotic prostates too, especially we had a patient with HIV, and in that patient, he ended up making 600 cc's of urine, and we had to irrigate his bladder several times. And at the end of the case, his bag had about 1,500 cc's of fluid. And so everyone was thankful we were using the Multiphze Enclosed Bladder Irrigation. We didn't have a basin of urine that was going from the OR table to the back table and back and forth that could have spilled. So again, this is the only enclosed OSHA compliant system. It's, as we said, it's extended PPE. And so, if for patients who have, for instance, MDR E. coli, MRSA, VRE, C. diff, or any kind of isolation protocols, or have HIV or hepatitis, why do you want to expose yourself to an open system when you can use this closed system to manually irrigate? Again, whether it's in the ER, the urology clinic, the med-surg, PACU, or OR. And what's nice is we did an animal lab study. And so not only do we enclose the system, but we cut the time to irrigate by more than half. So for first-time users, and we cut our spills to 0%. So for first-time users, we cut the time to irrigate at 1, 2, and 3 liter by more than half, which was all statistically significant. And this was for first-time users. In addition to that, we cut our spills to 0%. And you can see here from the animal lab study, this is the standard way. And these were seasoned urologists who were using it. You can see here that there were spills on the floor here. So you can imagine their gloves, their shoes, the tabletop they were working. And now look at the bladder, the Multiphze Enclosed Bladder Irrigation System. There's not a drop of blood anywhere. And that's after 3 liters of irrigation. You can see the bag is there full, but there's not a drop of blood anywhere. So with that being said, when there's not spillage, you can reduce the time to irrigate. It's 1 person irrigating versus 2. There's a lot of procedural cost benefits. So when you look at the overall procedural cost benefit, it's a lot cheaper actually to use our device, especially when you have to irrigate more than 2 to 4 liters. And on average, anecdotally, my experience, I usually have to irrigate somewhere between 2 and 4 liters for most patients. And we have a nice calculator on our website, so you can actually visit our website, put in the numbers you think, the time spent to irrigate, the actual costs, hourly rates of the physician, the nurse, what have you. But we have a really nice calculator on our website that I encourage you to visit and actually see the cost savings that you guys could potentially see at your facility. The other economic benefit we found is a lot of times when patients show up to the emergency room or our clinics post-op and they need a bladder irrigation why waste a 16 or 18 French Foley catheter kit? Because you really need a 20 or 22 French 2-way or 3-way catheter to irrigate. So in our facility, what the nurses do is instead of wasting a Foley catheter kit, they'll actually open our device between the patient's leg, drop their 20 or 22 French catheter. They'll actually plug the 3-way port with the spike from the cap from our spike. They'll separately place the betadine, Surgilube, and sterile water on the field. And then what they'll then do is connect the catheter to the syringe right off the bat. And so when they insert the catheter, it's already connected to the syringe. They'll verify they're in the bladder once it's inserted, fill up their balloon, and start irrigating. And you can see here, this is, again, after several liters of irrigation, there's not a drop of blood anywhere. And what they effectively did is they took the irrigation line, connected it to the patient's inlet port, as I described before. They took the 4-liter bag and connected to the drainage line, and they started immediate CBI. And you can see how the fluid's fairly clear after that. So there's an additional cost savings by not wasting that Foley catheter kit and that 2-liter bag that you don't need. I was going to spend a couple minutes here, just some tips and tricks when you're inserting catheters or doing bladder irrigation. What I find, by the way, sometimes I get called because people can't put in the catheters. The nurses are having a hard time. And a lot of times it's the patient just clamping down and tightening up their sphincter. So a lot of times when nurses can't get it or I'm having a difficult time, the first thing I do is tell the patient to spread their legs open, sort of to destabilize their sphincter contraction, if you will, to allow them to relax, as well as coaching them to relax. When you're irrigating, by the way, you always want to have a buffer of fluid in the bladder. If you're just irrigating, putting 50 in and trying to pull 50 out, or 120 in and pulling it out, there's a good chance you're going to be sucking on the bladder tissue. The patient's going to feel it, and it's going to clog your catheter, so you can't really irrigate. So always maintaining a buffer is a good idea. And like I mentioned before, you always want to have at least a 20 French or a 22 French catheter to irrigate. And if you didn't know that, it's much easier to irrigate through a two-way catheter because you have a larger luminal ID versus a three-way catheter where it's split between the inlet port and the drainage port. And one thing I've also seen when I've gone to irrigate patients, I've noticed they have a 30 cc balloon, Foley with a 30 cc balloon, and the 30 cc's is fully filled. The problem with that is it decreases the lumen of the catheter on the inside. So a lot of times you may need to take it down to 5 cc's. And irrigate through that. That way you can maximize the luminal diameter when you're trying to pull out big clots. And the one thing that I like to do is when I know I have a lot of clot to irrigate, rather than torture the patient, I usually will give the patient some pain medications. And that allows me to irrigate freely because this syringe is a 120 cc syringe versus the standard 60. So I can get through an irrigation much quicker. And ideally, when you're using irrigation fluid, make sure it hasn't been sitting under the air conditioner or it's cold. You want to at least have it room temperature if you can to minimize the bladder spasms on the patient as well. But with that being said, as I showed you these two pictures before, once you're done irrigating, there's no post-irrigation mess. And the time to clean up is literally down to a couple minutes. I've had nurses' jaws drop when they see me just wrap the drape around the multiphase syringe and we're done. There's no more like 15, 20 minutes trying to do that half roll on the patient, trying to change the sheet, wipe the gurney, all these other things, versus in this picture here, you can see what a biohazard scenario this whole picture is. And one thing, I'm just going to go back a couple slides here to show you. When I showed you this, this technique right here, the nice thing about this technique is, A, you don't waste a Foley catheter kit, but you don't break the sterile seal when you start irrigating, versus when you put a 16 or 18 French catheter, which I've seen nurses irrigate with, they're breaking that seal, which really troubles the infection prevention people of your hospital, that they're breaking that sterile seal and they start irrigating. And obviously you could see when they start irrigating the manual open way, it's just not sterile, it's not clean. It puts not only the nurse or the provider at risk for getting contaminated, but it also can put the patient at risk for a CAUTI. With our device, we're not breaking any sterile seals, so we're keeping the whole irrigation sterile. And again, you can turn the device to off before you transfer the irrigation line drainage bag while you're sterilely in that sterile position, again, to minimize the risk of a CAUTI. So with that being said, this is our corporate page, and I'm happy to start taking questions, Vic, at this point, or if you had any thoughts you wanted to ask or share.
Yeah, let's bring everybody on here. Righty. Great presentation, great device. It's one of those things where you kind of, it's like a wow moment. I think we lost Lori here, so let me just switch that off till she gets on. It's one of those kind of like wow moments when you see it, because we've all been through that struggle of trying to put through multiple syringes of fluid to try to get some out, and it's a huge mess. And at the very least, you're getting contamination because of breaking the seal, like you said. So I do have some questions coming in. I'm going to go right to those since we do have a few. Katie Bortel asks, do you ever have problems with blood clots? So do you have an issue as far as the size of your syringes as big as, I would guess, an irrigation syringe is, right?
Sure. So the tip of the syringe is no different than, that's a good question, by the way. People have asked that. So the tip of our syringe is no different than the standard irrigation syringe that people have been used to for several years. So pulling clots is not an issue through our device. In fact, when I use it on TURP cases, I can pull about 90% of my chips through that tip. Truth be told, we do have an OR version that's coming out with a detachable tip, sort of like a Toomey syringe. But in its current state, it could be used with the cystoscope adapter, and I can pull up pretty big chips with it, as well as any clots. Usually when the catheter gets clogged because it has a big clot at the tip or the catheter's clogged, that will happen with our device as well as a standard syringe. But once a clot goes through the catheter or the scope, there's no issues bringing it back into our device.
Yeah. And one of the things I wanted to comment on is you'd mentioned some tricks to putting in a catheter that you get called in because they have trouble. Because a lot of patients are really good at tightening their sphincter on you, and that can be the whole reason. So I like your idea with the spreading your legs, but the one I always do is I always kind of rest my arm on their thigh.
Okay.
So that I bring the catheter right up to the sphincter and tell them take some deep breaths, whatever your trick is. But I can feel when their thigh muscle relaxes, because nobody can tighten their sphincter without tightening their thigh muscle. So once you feel that relax, you can go and push that catheter through pretty easily. So just another point to add to that.
Thank you.
Lori, any things that you've had encounters with irrigation you wanted to share?
Well, I mean, this is great. I love it. I wish I could have used it years ago when I actually had a patient that was a hot mess, and there's cylinders of, clots and urine and what have you. And what happened is somebody in the room knocked over the Mayo stand with all of the blood. And it was all over the place. I mean, the hardest part is, carefully carrying things, so this would be a lot nicer and definitely prevent that.
Yeah. And it becomes a bloody battlefield. And I've spilled, if the patient, sometimes you're resting that 1 liter base in between the patient's leg, and they sort of wiggle because they're having a spasm, and they tip it over for you. So I've seen that happen. And even in the operating room, I'm putting that basin of urine on the Mayo stand in surgery, and didn't realize there was an instrument on the Mayo stand. It tipped over. It was already full. And then I put it and didn't realize it tipped over, and I'm spilling that. So you may argue, do you really need it in the operating room? It's like towing a jet ski with a semi. But in reality, again, if someone has some communicable disease or under isolation protocol, no one wants that urine spilling, and it's just a nice closed way to do it. So yeah, we've all been there with the mess.
Yeah, absolutely. I did have a question come in here I'd like to try to share with you guys. What evidence of clinical data do we have supporting the safety and effectiveness of the Multiphze system?
Sure. So for the animal lab study that I showed you, we haven't done, we are looking, we've been working with one of the local universities to set up a CAUTI study. We do feel that we should be able to reduce the CAUTI rates, if you will, from the manual bladder irrigation, but that study is still in the preparation phase. However, as I mentioned before, we did do an animal lab study at UC Irvine. And in that animal lab study, we cut the time to irrigate by more than half, and we cut the spills to 0. And that time that we reduced was statistically significant. And that was, again, for first-time users. So that's the clinical data, or the data that we've published so far.
Yeah. And for any of the new people out there to urology, if you've never done a bladder irrigation, to do it properly, you're talking, and Laura, you can back me up on this, 2, 3, 4 liters of fluid to irrigate until you get clear. I mean, you need to get it to where you see no clots, or it'll keep bleeding.
And that's even if you get it clear. This is a nice way to start, especially in an office setting, when you know that person's probably going to have to be transferred over to the hospital for, fulguration and so forth.
Right. And yeah, and like I mentioned before, if someone has a bladder full of clot, if you're starting CBI from the start, that's going to take forever. And when those clots, those little iceberg clots break off, they're going to clog your catheter. So you really want to irrigate clear as much as can. As a urologist, I don't want to get called back at midnight because the catheter's clogged and no one can irrigate. So I'm going to do my best to clear the clot. And of course, if I think that there's a clot I just can't break, or the patient's still anticoagulated, I'm going to start CBI obviously on them while I'm either trying to get them to the operating room, or because I'm waiting for their anticoagulation to correct, or I think there's still a remaining clot that I just want to clear out.
Yeah. Absolutely. Now, this would be a great question. Have you seen a difference in patient comfort compared to the old system where you're switching things? Because every time you switch the catheter out, you pull the syringe out to fill it up and put it back in, you are moving that catheter. There's no doubt. So what's the comfort level you think for patients?
So, obviously, with regards to this, you're not really moving the syringe around. You're holding yourself steady in our device because you connect it once to the patient's catheter. So that's one thing versus, you're turning your body, trying to drain, connecting. You have one hand that's clamping the catheter, things like that. Of course, sometimes you have to manipulate the catheter, push forward and back. Sometimes if you think you're trying to agitate the clot a little bit better. As I mentioned before, you want to have a buffer of fluid in the bladder just to make sure that you're not, pulling on the bladder mucosa. But as I mentioned, our syringe is a little bit larger. You don't have to fill the whole 120 cc's. But what I find is if I give the patient some pain meds and I can get through the bladder irrigation in half the time, the patient's actually more relieved than sitting there for 40 minutes or 35 minutes, 40 minutes waiting for me to go through, say, 4 or 5 liters of irrigation when I can do it in about 10, 15 minutes. So that's really the benefit for the patient is the quick irrigation time.
Yeah.
Where they're not tortured, if you will, for so long.
Is it possible? Sorry.
Yeah, go ahead, Laura.
Is it possible to get any kind of samples for an office just to try them out?
Sure. So we can work with, if anyone wants to reach out to us, I can put up our, it's info@multiphze.com. But what we can do is we can connect you to our local representative and also get on a quick Zoom to do a quick in-service as well. And we have a great in-service video on our website on our resource page. It's dubbed and everything. But yes, we can provide samples as needed.
Yeah.
Great.
What is the cost of the system?
So the list price is $125, although it should be on a large GPO within the next week or two. We're about to sign that agreement. It's already on another GPO, and there will be GPO pricing. And we're working with additional 2 large GPOs already. They're taking us through an innovative contract. So an innovative agreement, because this is a new device. It's not competing with any existing. There's no enclosed manual bladder irrigation system on the market. So, but the list price is $125 at this time.
Yeah. And as you showed in one of your slides, the difference in the amount of time it takes to clear somebody using your system versus standard, the old procedure. I would say at best 30 minutes. Would you say, Lori? For your best case scenario?
Absolutely.
That's 2 people, 30 minutes of labor that you're paying for too.
Right. And if one person can do it, and then if you think about isn't just the irrigation, it's the cleanup afterwards. No one has to sit there and I've seen nurses, I feel bad. I've left a bloody battlefield and I've seen the nurses now trying to get rid of the old sheet, change the patient's gown, get them new linens, wipe the gurney while the patient's still on it. And, and then they have to put a new sheet under there and everything else. So that takes time. And if you're in the ER and you got a large patient census to deal with, you can imagine nurses, and we've seen it, I get called to the ER, patient has gross hematuria, okay, irrigate. And getting the call, the nurse couldn't clear the bladder. I'm like, that was 2 hours ago. And it is because nurses will put it off as long as they can. And I get it because they don't want to sit there for 30, 40 minutes. And maybe after 10 minutes, they say, I can't clear the clot. And then the next thing you know, their ER is waiting for me to drive in another 30, 45 minutes for me to get in and sit there. So they just lengthen the patient's ER length of stay, because of this. If the nurses, and what we found is ER nurses love this, and they can actually get through the irrigation quicker. They can dispo the patient quicker, things like that, especially if it's a post-TURP bleed and all they really need to do is get the clot out and they can let the patient go home. They can do it much quicker with our device than like I mentioned before, is putting it off, waiting for me to drive in, what have you.
Yeah. And I'll say, as somebody who's done a lot of these in my career, the cramps I've gotten in my hand from trying to hold that catheter closed as I go to try to fill the other syringe. And then, as you say, you've got to keep some fluid in there. So you've got a buffer. And then you're going in there to irrigate, pull out. again, holding that catheter shut. I mean, it's just terrible.
You honestly, you bring up a good point, because I've had multiple blisters on my thumb from prolonged irrigations, and I've cramped my left hand holding. I'm a right-handed person, and I've literally cramped my left hand trying to squeeze a catheter, because not only you're trying to hold the buffer fluid in, but sometimes the patients are spasming and it's shooting the bloody urine out at you. So you're really trying to hold that in, and sometimes it gets really exhausting with both hands. And again, I've blistered my thumb multiple times using the old way.
So is this what happens when you take somebody who has an engineering background and put them into medicine?
It's that engineering.
Innovation.
I remember in residency, back in 1998, I started residency. And I remember the attending turning to me, because I was pointing out, hey, we can do it this way. And I think if we do this, and he said, Albert, why don't you learn the way we're doing it now before you try and innovate? So, but that's the engineer in you. You're always trying to think of efficiency and how to make it better.
Yeah,
so.
Absolutely. So I have another question for you here. Looking ahead, how do you see bladder irrigation evolving, and what role will the Multiphze play in standardizing best practice? Where do you see this?
So that's a really good question. So I did mention we have a couple iterations coming out. In fact, we started the IP. We've already submitted the intellectual property for an automated system. So that's really where we're headed, where you don't have to sit there and irrigate it. Just put it in the system and it'll automatically do the bladder irrigation, and it can go from manual to, if you will, continuous irrigation as needed, because it's in a system. So that's really where we're headed with this. It's funny, in many hospitals, including my own system, when you're taking your annual hospital safety training, there's nothing about bladder irrigation. It's all about how to deal with needles, how to deal with splashes and all this stuff.
Yeah.
But there's nothing regarding this. So we are trying to make that change. We are working with an infection prevention consultant, but it's not going to be an overnight change, just because a lot of us have become complacent to hematuria. It's amazing, for the last 20 plus years, I've been irrigating the same way since med school until now, so, and I was thankful in my own facility. I had nothing to do with its introduction. It got approved based on workplace safety. And it took only 3 units. They trialed it out at one of the facilities in Northern California. And it was accepted. From that 3-unit trial, we thought we were going to do a national trial, but they went from 3 units to pricing agreement. So they saw the workplace safety benefit of this. So you're right. It is going to be an evolving process, getting the word out, making people understand that hematuria is a bloodborne pathogen, whether it's in a needle or in the bladder, or a catheter. It still needs to be mitigated. The risk needs to be mitigated.
Yeah. All right.
And I was going to go back to that procedural cost, or the cost of the device. I know we talked about it's $125, but what I want people to realize too is, there is a reimbursement code 51700, which can reimburse up to $280 for the hospital. So theoretically, it should cover the cost of the device. But more importantly, what people don't realize is when they're using the old device and they're spending all that time, 2 people to do it, as you mentioned as well, there's bloody linens that need to be cleaned, all the cleanup that's required afterwards. There's a lot of procedural cost to that. And like I mentioned on our website, we have that calculator. And even though our device is at a certain price, we're actually cheaper when you look at overall procedural costs, especially when you have to irrigate 2 to 4 liters. We actually come in cheaper when you look at the global costs, or the global procedural costs of doing the bladder irrigation.
Yeah. And people forget about that hidden cost, like I said, with personnel, and you still have all the irrigation stuff that you've got to get together anyway. And you've got a system that's closed. I retired just recently, and boy, I almost like to go back just to try that system out.
I'll let you know about it.
Yeah. I was thankful, honestly. One of the pride and joys for me, if you will, is to be able to use it on my own patients, to be able to take this from a napkin and start using it. That's for me been the biggest reward, to be able to do that. So, but yeah, so if you can go back, I would highly encourage to use it.
It's not that if I can go back, I'm having too much fun doing this now, and I've paid my dues. After 40 years of urology, I think I deserve a little rest.
You do. So, yeah.
So, Lori,
And-
you're anxious to give it a try, huh?
Yeah, I would love to give it a try. I think it's interesting and I don't know, something new, you know.
Any of us that have been through that battlefield know that there's a better way out there, and it's glad to know it's out there now.
Right.
Absolutely.
So,
all right. I don't see any other questions coming in. So, any final remarks you have that you want to make, or?
Yeah, just to give you a little bit more information, we are available in the U.S. We're actually international as well, in the Middle East countries, in Qatar, UAE, and now working on our Saudi FDA. But otherwise, like I mentioned, we should be on one very large GPO, hopefully by the end of this month. And we're working on 2 other GPOs. But either way, you don't have to go through the GPO to order. And we'd be happy to set up in-service. We have a nurse educator that can come by as well and do an in-service training. As well as I mentioned, we have a great video. We have a lot of resources on our webpage, on our website, I should say. So I would encourage anyone who's interested to reach out to us. And I'm happy to share my contact information if anyone likes, or at any time.
Okay, that's great. Yeah, and we have a pretty large international audience that watches the show. I was surprised to find out there's 60 countries that actually watch UroNurse. So,
that's awesome.
There could be
Congrats.
demand from abroad. I've had a few companies that have put products out, and people are sending me mail saying, "I want to get this device. How do I get it?" So I'm glad to hear it's going to be available. All right. Well, I've got a little plug for next week's show.
Should we rethink how we prevent infections before a prostate biopsy? In this insightful episode, Vic Senese sits down with urology expert Dr. Nancy Brownlee to explore what the latest research reveals about targeted antibiotic prophylaxis before prostate biopsy. With rising antibiotic resistance and concerns about overuse, many experts advocate for a more precise, evidence-based approach to prophylaxis. Dr. Brownlee breaks down the data, explains the risks and benefits of targeted strategies, and offers practical guidance for healthcare professionals navigating this critical aspect of urologic care. Join us on August 30th at 9 a.m. Central Time to learn more.
Yeah, so next week we'll revisit the prostate biopsy and what's the best way to prep patients for it. I know there's a lot of different things out there, and somebody who's been involved in prostate biopsy, I'm anxious to hear more about that. So, hey, it's been great, Dr. Mikhail. Pleasure having you on the show. Lori, always fun to talk and enjoy time with you. So for the rest of you, we'll see everybody next week on UroNurse.com.
So here's to the mornings, the coffee, the monitor glow, to the wisdom he shares and the folks that he knows. Saturday is special when Vic's on the stream with 40 years of knowledge and a head full of dreams.